Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today we will discuss few MCQs from pediatric cardiology. Some of the students are repeatedly asking me to give a talk on multiple choice questions. Today we will touch upon the MCQs from pediatric cardiology. Let us go about it. This is the normal heart. We salute the heart before you go into the multiple choice questions on this particular topic. Question number 1. A 23-year-old primate delivered preterm baby with legal conotruncal congenital heart defects. She discloses the history that she was prescribed some vitamins during her antenatal checkup in the second month of gestation, except which she did not take any medication. Congeners which of the following vitamins is the cause of these anomalies? Number 1, vitamin B12. Number 2, vitamin A. Number 3, folic acid. And number 4, vitamin B6. That means here in this question, you see the baby is having lethal conotruncal congenital heart defects. Conotruncal congenital heart defects. What do you mean by that? It is the great vessels that develop from the conotruncus. If they fail to rotate, if there is failure of the development of the spiral septum, it results in transposition of the great vessels. That is the most common anomaly associated with conotruncal developmental defects. Let us see this picture. This picture shows transposition of the great arteries. Aorta arising from the right ventricle, pulmonary trunk arising from the left ventricle. This is the common conotruncal defect, and the baby will be suffering from severe cyanosis and congestive heart failure at birth. Then mother will be very much worried about the infant, and she will be interested to know the cause of this anomaly in her baby. So what are you going to tell her? It is the congeners of vitamin A sometimes responsible for conotruncal congenital heart defects. This is option B is the right answer. Then coming to the next question. Look at this. All the following statements related to the fetal circulation are true except. So it is a question on the fetal circulation. If you know about the fetal circulation, it is very easy to answer the question. The options being A. Inferior vena cava blood ultimately perfuses upper extremities. Ductus venosus connects umbilical vein with liver. The B. C. Superior vena cava blood ultimately perfuses lower extremities. D. Pulmonary vascular resistance is relatively high in the fetus. So as you know, it is all about the fetal circulatory system. Inferior vena cava blood perfuses upper extremities. Is it right? If it is right, how the upper extremities receive the blood? How it is from the inferior vena cava? So as you know, upper extremities receive the blood from the common carotid and the subclavian arteries. How these branches from the arch of the aorta receive the blood from the inferior vena cava? As you look into the fetal circulation, inferior vena cava empties into the right atrium. On its way, it receives ductus venosus from umbilical vein. Umbilical venous blood is better oxygenated, get mixed with the inferior vena cava blood, which is pumped into the right atrium. It goes preferentially into the left atrium through the foramen ovale. The left atrium empties into the left ventricle, and left ventricle ejects its content into the aorta. Aorta gives away branches, the carotids and the subclavians, supplying the upper extremities. That means it is the inferior vena cava blood going into the right atrium, from there pumped into the left atrium through foramen ovale, in turn goes into the left ventricle and pumped to the upper extremities and the brain through the branches of the archa of the aorta. So this explains that inferior vena cava blood ultimately perfuses upper extremities. Got the point? Yes, this is right on. This is the right option. But with regard to the fetal circulation, this point is correct. So all the statements are true except what? This statement is true with regard to the fetal circulation. Ductus venosus connects the umbilical vein with liver. Is it statement is true or false? As I told you, umbilical vein is connected with the inferior vena cava through ductus venosus. That means ductus venosus connects the umbilical vein with the inferior vena cava, not with the liver. So this is the right answer. The other one, superior vena cava blood ultimately perfuses the lower extremities. Is it right statement in the fetal circulation? This is what happens in the fetal circulation? Yes, it is right. Because superior vena cava blood draining the upper extremities empties into the right atrium, which goes directly into the right ventricle. Right ventricle empties into the pulmonary trunk. Because of the high resistance in the pulmonary circulation, the blood from the pulmonary trunk goes into the descending aorta through ductus arteriosus. Okay? And ultimately supplies the trunk and the lower extremities. And that's how the superior vena cava blood in the fetal circulation perfuses the lower extremities. You got the explanation? Yes, that's how it is. And the pulmonary vascular resistance is high during fetal life. Yes, this is right. So what is false is the ductus venosus is the structure that connects the umbilical vein not with the liver, with the inferior vena cava. So rest of the statements are right except option B. So option B is the right answer. The third question. An infant diagnosed at tetralogy with mild to moderate degree of pulmonary outflow obstruction comes to you with paroxysmal dyspneic attack. So your line of management includes each of the following except. So there is one option which is not correct. Then avoid dehydration, because dehydration is a triggering factor for anoxic spells. Advise iron. Well, iron is plays some role to prevent the recurrent attacks of anoxic spell in tetralogy of Fallot. Advise prophylaxis to propranolol is right. And surgery around school age. You should not delay the surgery in a child with tetralogy of Fallot, because early correction is going to avoid the morbidity and the mortality. Well, you know everything about tetralogy of Fallot. You need not to give any explanation about that. But if you want to know, tetralogy of Fallot includes large VSD, overriding of the aorta, pulmonary obstruction, and right ventricular hypertrophy. And anoxic blue cell spells are very common in mild to moderate degree of tetralogy fallows. And it is a medical emergency. Unless you treat properly, child is going to die. So early correction is always advisable in a child with tetralogy fallows. Next, coming to the question, a 12-year-old girl comes to you complaining of headache. It's very common in girls. She did not have proper sleep for the past few days due to stress of examinations. She is subjected to stress. You have noted her blood pressure above 95th percentile for age and sex. Which of the following is your best advice? Are you going to prescribe antihypertensive drugs? Are you going to disclose the diagnosis as hypertension? Are you going to subject the child for lab evaluation? Or you want to repeat the procedure? Which is the right answer? Obviously it is A is the right answer. Because child is subjected to stress, naturally her blood pressure will be elevated. So it is better to evaluate the child and repeat the procedure after a day or two, and ask the child come relaxed after the examinations to check her blood pressure. There is no hurry for the antihypertensives or the lab evaluation because the blood pressure is just above the 95th percentile. Coming to next question. A 2-year-old child develops fever about 3 weeks after a total corrective surgery for tetralogy fallows. Well, 3 consecutive blood cultures for common and uncommon bacteria for infective endocarditis are negative. 2D echo shows presence of vegetations at the root of the great vessels. The antibiotic therapy did not show any response. There is increasing size of the vegetation on repeat 2D echo. The child is likely to develop any of the following complications except, well, could you understand the question? The child is post-operative tetralogy fallows. That is 3 weeks post-operative. Develops fever. And there are vegetations at the base of the great vessels. The great vessels are the arteries emerging from the left ventricle and the right ventricle. That is at the base of the great vessels, means at the base of the pulmonary trunk and the base of the aorta. Well, and if there is inflammation and pathology at the base of the aorta and the pulmonary trunk, the child may suffer from refractory heart failure because of severe incompetence of these valves. Pulmonary embolism is a risk of the presence of vegetation at the base of the pulmonary trunk. Embolic stroke with cerebral embolism is again a complication. Myocardial abscess is uncommon rather when compared to the rest of the complications. So the right answer is C. It's mentioned here, it is wrong. Answer is C. A 2-year-old child, that is a 2-year-old child diagnosed with ascending congenital heart disease has been on congestive conservative treatment. A 2-year-old child diagnosed ascending congenital heart disease has been on conservative treatment. Well, when you review the investigations, revealed presence of cardiomegaly, pulmonary hyperemia on the chest X-ray. ECG showed signs of biventricular hypertrophy. Any of the following would be your diagnostic possibilities, except here mother brings her child's chest X-ray and the ECG report. For the follow-up of her child, diagnosed and being on the conservative treatment for synovial congenital heart disease. Right? Then the findings are there is cardiomegaly, pulmonary hyperemia on X-ray chest, and biventricular hypertrophy in the ECG. Then what could be the diagnosis? AV septal defect, pulmonary stenosis, VSD, or PDA. It could be anything except. So the question is, any of the following would be your diagnostic possibilities except. Diagnostic possibilities except. X-ray showing pulmonary hyperemia indicates volume overloading of the pulmonary circulation. Volume overloading of the pulmonary circulation occurs with left to right shunts. Right? So it could be VSD, it could be PDA, it could be AV septal defects, but cannot be pulmonary stenosis. In pulmonary stenosis, there is oligemia of the lung fields because of the reduced pulmonary flow due to pulmonary stenosis. So there is obstruction to the right ventricular outflow. So there is reduced pulmonary flow. So lung fields will show hypovolemia or oligemic lung fields. So the answer is option B. Well, the X-ray findings are, you see the picture. You see the cardiomegaly, pulmonary congestion. Well, we'll conclude the class today at this point of time. Thank you very much for patient listening. Hope the MCQs are interesting for you, and give me the feedback. And if you like the MCQs, we'll continue the discussion of MCQs in different chapters. I have all the MCQs in pediatric cardiology, pediatric endocrinology, pediatric neurology. Well, if you are interested, my dear students, we'll talk briefly in the coming classes. Until that time, thank you very much and bye-bye.